Respected chairpersons, learned viewers and listeners of this program, of course, former friends, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on the pleiotropic effects of oral semaglutide beyond glycemic control with a particular focus on outcome. My financial disclosures, I have no potential or actual conflict of interest in relation to my presentation. The agenda includes cardiovascular mechanisms of oral semaglutide, effects of oral semaglutide on biomarkers and its pleiotropic benefits, and of course, summary. Type 2 diabetes is a major risk factor for cardiovascular disease, and that both type 2 diabetes and cardiovascular disease increases the risk for death. Despite major therapeutic advances leading to improved outcomes, cardiovascular disease remains the major cause of mortality in patients with the type 2 diabetes. So very importantly, accordingly, the development of treatment strategies to minimize or to improve the cardiovascular outcomes in this particular vulnerable patient remains a major priority. So the progressive complexity of patients with the type 2 diabetes translates the need for modification, that is, need to modify and individualize the anti-hyperglycemic medications with a view to improve the glycemic control and also slow the advancement of the disease. So that is very important while managing patient with type 2 diabetes. So very important thing is cardiovascular data. So newer agents proven to reduce the cardiovascular events, improve cardiovascular outcomes in patients with the type 2 diabetes, have shifted the paradigm, shifted with reference to the management of hyperglycemia with a particular focus to include broad range of comprehensive cardiovascular risk reductions. So with these few words of introduction, let me take you all through my presentation on this particular topic. So cardiovascular disease is the leading cause of disability and death for patients with the type 2 diabetes, accounting for approximately 75% of patients with the type 2 or risk of CVD. Many people already have macrovascular complications by the time they are diagnosed. So patients with the type 2 diabetes, newly diagnosed, may have microalbuminuria, may have neuropathy, may have retinopathy. So the ticking clock hypothesis, which states that the clock starts ticking for the macrovascular complications before the onset of type 2 diabetes. So worldwide, 1% dies every 8 seconds from diabetes and its complications. 50% of deaths in patients with the type 2 are attributable to cardiovascular disease. 85% of deaths from cardiovascular disease are due to atherosclerotic cardiovascular disease. Cardiovascular disease was the cause of death in 2 out of 3 people with the type 2 diabetes greater than 65 years on an average. At the top of 60 years, life expectancy is reduced by 12 years for a person with the type 2 diabetes who has experienced a heart attack or stroke. So mechanism may explain the cardiovascular benefit. GLP-1, that is this peptide, was discovered as an insulinotropic glucagonostatic peptide and subsequently shown to have a beneficial effect with reference to cardiovascular events. Right. So the liraglutide, albiglutide, next is dulaglutide, and semaglutide. Various trials have clearly shown there is a difference with reference to cardiovascular outcome. So if you look into the effect of the GLP-1 and GLP-1 receptor analogues, it has an action on insulin resistance, body weight reduction, and reduces inflammation with a favorable impact on lipid metabolism, direct effect on myocardium and endothelial function, and reduction with reference to blood pressure, and reduction of hyper and hyperglycemia. And this effects results in anti-atherosclerotic effects, cardioprotection, and cardiovascular benefits mediated primarily through improving the cardiac output, myocardial contractility, improving endothelial function, glucose uptake with a favorable impact on cardiac protection, plaque stability, and reduction with reference to arterial stiffness, hypertension, as well as vascular inflammation and platelet aggregations. So GLP-1 receptor analogues. Preclinical studies, including DPP-4 inhibitors, have clearly shown cardioprotection in animal models with reference to myocardial ischemia as well as with reference to LV dysfunction. So the anti-atherosclerotic mechanisms of GLP-1 has been mediated through various actions in various organs and tissues. So in the intestine, it reduces the generation or the production of ApoB48, which is important for the transport of cholesterol and triglyceride-rich proteins to the liver, and also reduces the triacylglycerol secretion as well as fatty acid secretion. So favorably, it improves the endothelial function in that reduces inflammation, oxidative stress, and favorably increases the nitric oxide synthase production. Next is with reference to smooth muscle proliferation. It also has a favorable effect on the macrophage as well as sperm cell. Next is in the brain. It suppresses appetite. The signals are primarily transmitted through vagus nerve to the nucleus tractus solitarius as well as to the area posterior. From there, it is conveyed to the higher centers in the brain as well as to the thalamus and the hypothalamus. And above all, it has been associated with the reduction in atherosclerotic plaque formation. So the effects beyond glycemic control in patients with the type 2 diabetes to address the cardiovascular risk with atherosclerotic cardiovascular risk modification by direct and indirect effects. So the GLP-1 receptor peptide acts primarily through activation of the GLP-1 receptor 1. It has also got non-GLP-1 receptor mediated action, number one. Second thing is, it also stimulates the pancreatic beta cells to secrete insulin. So insulin mediated action, insulin dependent action, as well as insulin independent action. So ultimately, it has got a direct as well as indirect effect with a positive effect on the inflammation, oxidative stress, and the risk factors for atherosclerotic cardiovascular disease. GLP-1 receptor analogues in ischemic stroke, the proposed molecular mechanism, the preclinical studies for neuroprotective mechanisms of GLP-1 receptor with reference to ischemic stroke. What are the possible mechanisms? There is increase in the GLP-1 receptor expression. That is, GLP-1 receptors are expressed in various parts of the brain, including the hypothalamus as well as thalamus, and that activation of the downstream pathways, number one. Next is effects on reducing inflammation, endothelial permeability as well as excitotoxicity, decreased production of reactive oxygen species and reduced cerebral edema, and neuronal regeneration and apoptosis mechanism with a positive impact on cognitive functional outcomes and increased cerebral blood flow. So the GLP-1 receptors, which are released from the intestine, they transmit the impulse through the vagus nerve to the nucleus tractus solitarius as well as to the area posterior. From there, it is carried to the higher centers in the brain with a favorable impact on the various inhibitor signals as well as the positive signals with reference which normally regulates the appetite, hunger, satiety. All right. Next is the burden of cardiovascular disease in patients with the type 2 diabetes. The capture study, the first global study to uncover the prevalence of cardiovascular disease in patients with the type 2 diabetes. 1/3 of all people with the type 2 diabetes have established cardiovascular disease. 9 out of 10 patients with type 2 diabetes and established cardiovascular disease have atherosclerotic cardiovascular disease. Only 2 out of 10 patients with type 2 diabetes are getting a glucose-lowering treatment with a proven cardiovascular benefit. So what is the key message? The prevalence of atherosclerotic cardiovascular disease with the type 2 diabetes population is high, and that vast majority are not being managed with treatments that are proven to reduce the risk of life-altering cardiovascular events. So GLP-1 receptor have established glucose-lowering effect. In addition, it has got also cardiovascular safety, that is the 2 trials with reference to lixisenatide and exenatide. They have shown cardiovascular safety, no cardiovascular benefit. With reference to liraglutide, albiglutide, dulaglutide, and semaglutide, these trials have clearly shown the cardiovascular benefit. Right. So Pioneer 6, these studies were highlighted by Dr. Manoj Chawla. So Pioneer 6, phase 3A trial, that is the pre-approval cardiovascular trial, randomized placebo-controlled trial. This particular trial was conducted to evaluate the cardiovascular safety of oral semaglutide. That is there any cardiovascular excess risk in patients for oral semaglutide compared with placebo? And patients were randomized to receive 14 milligram of oral semaglutide, and another group received the placebo. So if you look into the primary endpoint, that is time from randomization to the first occurrence of the primary composite endpoint, 3P MACE, cardiovascular death, non-fatal MI, non-fatal stroke. So with reference to primary endpoint, so 61 events in the group that has received the oral semaglutide compared to 76 events in the group that received the placebo. If you look into the Kaplan-Meier curve, the curves start separating much early, And if you look into the hazard ratio, already this was pointed nicely by Dr. Manoj. This particular trial demonstrated non-inferiority for oral semaglutide as compared with the placebo with reference to primary endpoint, that is corresponding to hazard ratio of 21%, that is with reference to the difference in the risk. Next is the if you look into the analysis of the individual components of the primary endpoint with reference to cardiovascular death. So there was for 15% reduction in the risk compared to placebo for oral semaglutide. Next is the time for the first event of non-fatal stroke. That occurred 12 events with reference to patient in the semaglutide arm and 16 events in the placebo arm. With reference to non-fatal MI, 37 events in the placebo and 31 events with reference to semaglutide arm. Next is all-cause death, hazard ratio of 0.51. So 23 events in the semaglutide and 45 events in the placebo arm. So if you look into the hazard ratio, that is 49% lower in the patients treated with the semaglutide. Next is effect on blood pressure. So oral semaglutide reduces systolic BP by up to 5 millimeters. What are the mechanisms that are underlying the reduction in the blood pressure? One is there is improvement with reference to the glycemic control. So improvement with reference to endothelial function, number one. Second thing is therapy has been associated with the natriuresis. So excessive sodium loss that can also reduce the blood pressure. Next is there is a difference with reference to atrial natriuretic peptide levels. Next is suppression or reduction or inhibition of the renin-angiotensin aldosterone mediated mechanism. Next is effect of oral semaglutide on lipid profile with reference to triglycerides, with reference to free fatty acids, triglyceride-rich VLDL as well as apolipoprotein B48. So oral semaglutide improves fasting and postprandial lipid profile after fat-rich breakfast. Next is pulled later. It provides the best current evidence for cardiovascular outcomes with the semaglutide. Individual trial data and post-hoc combined analysis. So this they have taken into account analysis of the individual component of the 3 MACE and other cardiovascular outcomes. They were analyzed with reference to the SUSTAIN 6 patients participated in the trial. They received the injectable once weekly semaglutide and Pioneer 6 oral semaglutide. This was also highlighted nicely by Dr. Manoj Chawla. So very important thing is whether you give it subcutaneously once weekly or whether give it orally, after absorption, subcutaneous and oral semaglutide have similar pharmacokinetic and similar pharmacodynamic effects. That is very important. And if you look into the MACE events, no difference at all with reference to hazard ratio. On the other hand, if you look into the individual component with reference to hazard ratio, it is less than 1 only for few individual components, especially non-fatal myocardial infarction, whereas the rest of the individual component, it is not less than 1. It is not less than 1. So if you look into combined data of the SUSTAIN 6 as well as with reference to the Pioneer 6, the hazard ratio is less than 1 with reference to the MACE, not for the individual component. There is no difference with reference to p-value for interaction, whether the patient had established cardiovascular disease or whether the patient had CKD or whether looking to other events, number 2. Third important thing is the hazard ratio for MACE remains same, thereby highlighting the regardless of the route of administration, semaglutide behaves in a same or similar manner. So the incidence rates of MACE were 3.1 and 4.2 events per 100 subject years with the semaglutide and placebo respectively. That is 24% reduction in 3P MACE and a hazard ratio 0.76%. So the semaglutide reduces the incidence of stroke. This was presented in EASD 2020, the cumulative incidence of stroke over time. So the pooled data showed a significant reduction of 32% in risk of stroke compared to placebo. Right. Next is post-hoc exploratory subgroup analysis of SUSTAIN 6 and Pioneer 6, patient on metformin or patient without metformin. Semaglutide reduced the risk of MACE regardless of the baseline metformin use. So on the standard of treatment, whether you give it once weekly subcutaneously or once daily orally, semaglutide reduces the risk of MACE in patients with the type 2 diabetes with a high cardiovascular risk. So cardiovascular safety of oral semaglutide. Summary, when oral semaglutide added to standard of care, therapy has been associated with a non-inferiority for MACE, that is 21% reduction in the risk compared to placebo, and cardiovascular death by 51% compared to placebo, and 49% risk reduction with reference to all-cause mortality compared with placebo. Besides, it induces reduction in A1C and body weight as already highlighted by Dr. Manjushri. Overall, the AE profile was consistent with the GLP-1 receptor analog. So the G-related symptoms, nausea, vomiting, diarrhea. So next is the effect of oral semaglutide and biomarkers and its pleiotropic benefits. So Pioneer 1, drug-naive, type 2 patients, type 2 diabetic patients failed to achieve significant control on A1C with the diet alone. When given compared to monotherapy, there was significant impact on the reduction with reference to C-reactive protein. So Pioneer 2, empagliflozin, compared to EMPA 25 milligram, there was significant reduction with reference to the CRP apart from its effect on A1C and body weight highlighted by Dr. Manjushri. So inflammatory markers such as CRP shown to come down with the use of oral semaglutide. Effect on lipid parameters with reference to triglycerides, VLDL, free fatty acids, and ApoB48. I have already enumerated two. This particular. Next is decrease in postprandial lipids with reference to triglycerides, VLDL, and ApoB. Next is effect on lipid parameters with reference to total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. Kindly look into the levels of the triglycerides and LDL. They are moderately lower in patients treated with the semaglutide compared to patients on placebo. So decrease in total cholesterol and LDL and triglycerides. So effects on blood pressure compared to placebo or other comparators, there was significant impact and mechanisms I have already alluded to. So reduction in systolic blood pressure up to 5 millimeters of mercury. So this is a very important study. That is animal experiment model. That is ApoE deficient, that is ApoE knockout mice as well as LDL receptor mice. So the administration of semaglutide was associated with dose-dependent reduction with reference to body weight as well as plaque lesion area. So dose-dependent reduction in the plaque lesion development. Next is mechanism of action for weight loss. Several mechanisms have been attributed to therapy associated weight loss. One is predominantly loss of body fat mass compared to lean mass. That is with reference to the bone, with reference to body fluids, with reference to individual organ, with reference to skeletal muscles. Next is reduced energy intake, with reference to hunger, with reference to food meal size, with reference to time span, with reference to the quantity. Next is decrease in the resting metabolic rate. And above all, the important points with reference to hunger, cravings, satiety, and control. So the mechanism of action for weight loss, energy intake with oral semaglutide, that is following a lunch, following an evening meal, following a snack box, and total. So they have assessed the quantity of the meal with reference to semaglutide. There was 39% decrease in the total daily energy intake with oral semaglutide. So energy intake has been drastically reduced in patients on semaglutide compared to patients on other comparators or the placebo. So reduced energy intake. Next is mechanism of action for weight loss with reference to appetite ratings after fat-rich breakfast meal. So they have given standard meal. They assess the mean postprandial ratings, number one. Second thing is they assess the 4 important points with reference to satiety. Next is with reference to hunger. Next with reference to the food consumption, with reference to the protective food consumption. So what was the result? Decreased preference to high fat and sweet foods. There is improved eating control coupled with a reduction in the overall appetite score. Palatability was consistent across groups, indicating that nausea or food aversion were not the cause for decreased energy intake. So the mechanism of action again, reduction in the whole body fat mass. So reduction in whole body fat mass and reduction in the whole body lean mass. So body weight reduction mainly in the form of loss of fat mass with no effect on lean mass. So kindly focus your attention on the oral sema compared to placebo on different parameters with reference to body weight, whole body fat, and whole body lean mass, and fat percentage. So summary. So disappearing mechanisms for pleiotropic effects. They targets. So it stimulates the pancreatic beta cells to secrete insulin in a glucose-dependent manner. Suppresses alpha cell to release glucagon, gluconostatic action. Induces natriuresis and diuresis. Appetite suppression and cell survival. Intermediate effects. Reduces inflammation, postprandial lipids, improves beta survival function, potential neuroprotective effect, improves LV function, and alters the coagulation parameters. The final effects are reduction in A1C, blood pressure, urinary albumin excretion, body weight, cardiovascular events, and hepatic injury. Thank you very much for your kind listening. Please remain safe and take care, stay connected, and stay healthy. Thank you very much.
Thank you.